Well, good morning and thank you for the introduction. Well, it is a honor to, to present my comments, but also there is a lot of difficulty after listening to Kiran and me, and just a poor clinician to talk anyway. I have to thank Georgia and the whole team downstairs for letting us share with you all our problems, all our anxiety. I don't know, you have to count how many times we call you during the day or even the week, and she's always there, and not only, and Christina and Evie and everyone. So thank you once again for this. Okay. I'm not going to say anything about that, but you can see how a red marrow becomes yellow by losing water, losing protein, and getting a lot of fat as the time goes on, as children grow. And this is something that we heard and we saw today. I don't see any point. Okay, thank you. How an infant starts with the red marrow, and as he or she gets older, marrow is being substituted by the yellow marrow. I found this paper and I found it quite interesting. However, there's not much about pediatrics in this, but there were like 50,000 MRI studies. They excluded patients that they had an MRI and they didn't find anything in the bone marrow, or they did not have cancer. They knew they did not have cancer. And they were left finally with 110 patients that they analyzed. So it was interesting that they found a large number of bone marrow lesions, the majority in the lumbar spine. And then they tell us in this paper what they did afterwards, what they did, CBC, bone marrow, bone scan, a biopsy, and so on. And what, out of these 110 cases, I hate to say cases, patients, and most of them were not children, like I said, so they ended up in this very tiny number of really picking up a malignancy, okay? We have heard already by Kiran about the conditions that they may alter the bone marrow in children. So let me also go very fast. The non-malignant, I'm not going to play with this. The malignant, early and late effects of therapy, and some other issues. I'm not going to stay into this at all, but the infiltrative diseases, but I will stay in this subgroup down there. And, this subgroup gave us hard time some time ago, really hard time, and gave to Georgia as well hard time. So this is an adolescent, 17-year-old with osteosarcoma, amputated due to local relapse. Later he developed also pulmonary disease. He's a cyclist, he's biking. He's been exercising a lot. He's not eating very well. He says he does, and his dream is to go to Paralympics next year, and I'm pretty sure he will manage to do so. So, look at these pictures that we saw during the follow-up. So we saw diffuse abnormality, the red arrow in the bone marrow, and also it was noted that he didn't have any subcutaneous fat. However, we had to do things, okay? This was a child heavily pretreated, so he could have myelodysplasia, he could have secondary leukemia, and so on. We went through a hell, let me tell you, up to the time we got back our answers. Let me share with you something also that Nicholas let me take a picture on that. There is a date there, if you can appreciate. This is the day he lost his leg. So, and this is a tattoo he made afterwards in his arm. So I have his okay to present it. So all the investigation came back negative, and as the time was going on, 4 months later and 8 months later, he started eating better, exercising same way, but his bone marrow improved, and even you can see he started having some fat. And he's in remission right now, and like I said, he's hoping that next year he will go into the Paralympics. He's swimming as well, not only that. This is another child referred to our department, 4.5-year-old boy. He was limping, who refused to walk. He had low-grade fever, but his CBCs were normal, absolutely normal. In the pediatric department, after checking him for various reasons of his fever, of his limping, well, to our surprise, they did an MRI, but they did an MRI, and look at this. Look at these bones, this bone marrow, rather. He had a very suspicious and abnormal bone marrow signal. And we said it was a weekend, if I recall. What are we going to do now? So his CBC, like I said, it was completely normal WBC, good platelet count, good polis, neutrophils. However, we're somehow pressed to do a bone marrow in the weekend, and here we are. The child had acute lymphoblastic leukemia B origin. And he's well, he's in remission, and he continues his therapy. This is another child, 12.5-year-old boy with jaw pain, floating teeth, please keep this, and swelling of his jaw. He comes from northern Greece, and various studies were undertaken. So we can see abnormal bone marrow signal intensity, periosteal reaction, and a soft tissue mass. In Thessaloniki, in northern Greece, a jaw biopsy was done, which showed a Burkitt's lymphoma. I'd like to go back and show you these floating teeth. In pediatric oncology, if we hear about floating teeth, our first diagnosis is LCH, and the second one might be Burkitt's lymphoma. Now, with our third patient, the next patient rather, it's not the third, it's a 6.5-year-old girl with fever, bone pains, very painful gait, and she couldn't walk, and when she was walking, she was still, she couldn't bend her spine, and she had jaw numbness. Trust me that this bothered me more than anything else. So the first diagnosis was CRMO, correct? Okay. I didn't like that jaw numbness because this goes together with the floating teeth. She didn't have floating teeth, but with trigeminal involvement from something, maybe. So this is our patient. She had abnormal replacement of her bone marrow. As you can see in these pictures, I'm not going, I feel, so uncomfortable in showing pictures after your presentation and all these radiology people that you have come today. But we did a bone marrow, and this is the classic, I can show this, I know that very well, and this is the classical picture of Burkitt's leukemia, those very large blue cells with a lot of vacuoles. It's like a textbook. This is a Burkitt's leukemia. So in this child and in the previous child, there were findings of their Burkitt's in the bone marrow MRI. Okay, Kieran said already about primary tumors of the bones or metastasis in neuroblastoma. Okay, this is a patient of mine who had from Children's Hospital, not from here, with marrow involvement and soft tissue mass. And I'm going to talk a little later about neuroblastoma. Now, in this hospital, we have come across another entity, which we now call chronic or adult neuroblastoma, very peculiar disease, very strange disease. She was almost 17 at the time of diagnosis. She had a right adrenal mass or a left adrenal, I don't remember right now, and she was referred to us. And her bones and bone marrow at that time were negative, both by bone marrow biopsy and aspiration, trephines, MIBG, and so on. But 3 years later, during her follow-up evaluation, and at the time that we felt that she was in complete remission, actually she wasn't, because she had a diffusely abnormal bone marrow. I was telling Georgia, no, I don't believe this. No, she doesn't have anything. She had a PET CT and everything. And she had also focal bone disease. However, a biopsy was undertaken by Dr. Andreu, and the diagnosis of her relapse was made. It is interesting that this week, on Thursday, she had follow-up studies, and Georgia was very anxious because her marrow was very red, correct? So I told her that this child is to go for MIBG therapy in Germany. So she had huge doses of for GCSF, double doses actually, at a point that her WBCs in Germany went up to 54-something thousand per cubic millimeter. So nothing wrong with her, everything is fine. Now, this is another case. I noticed that Kieran showed a medulloblastoma in a foot, right? For me, medulloblastoma is a very interesting story, you know, because my first presentation when I was in the States as a very young clinician in my fellowship, it was at the ASCO meeting, the extraaxial spread of medulloblastoma, and at that time I presented 3 children with metastatic disease in the bones. And I was surprised when I read at that time that those metastatic lesions are osteoblastic, exactly like prostate cancer in the adults. And since then, I haven't seen anything. And the explanation for seeing less and less metastatic extraaxial spread is that now we don't treat our patients with surgery, radiotherapy, period, but we give a lot of chemotherapy as well. Okay, so this is a 9-year-old girl with metastatic medulloblastoma to the CNS at the time of diagnosis. 8 months after diagnosis, her disease had progressed with meningeal, intraspinal, and bone disease. And I can show you the bone disease here. Okay, this is a CT, it's not an MRI. But 2 months afterwards, she had a drop in her WBC, drop in her platelets, I mean 80,000 platelet count, and some abnormal cells in the peripheral blood. So we elected to look for those cells in another way with cytology, and this percentage of blasts were positive in CD56, which is a hallmark for medulloblastoma. But still we said 3%, it doesn't say much. So we went further and we did a bone marrow aspiration where synaptophysin, chromogranin, NNC, and CD56 were positive, as well as 50% of the bone marrow was occupied by those strange cells that were CD56 positive. So this was a very rare case that we don't see lately because, like I said, we use very aggressive chemotherapy, which takes care of all the metastatic disease. This is a paper from skeletal radiology with 70 patients, and 47% of those in the bone marrow following therapy for soft tissue sarcoma had focal or diffuse changes in their bone marrow. And look that the majority, 58 to 71%, had received chemotherapy plus radiotherapy. Now, we already heard about effects of therapy, the marrow regeneration after growth factors, you can see here, and then the late effects of therapy as marrow necrosis and AVN, avascular necrosis. I have to say regarding AVN that Greece, since last year, is collaborating with a big group in Dana-Farber Cancer Institute, because we had quite a number of AVNs. They were girls. They usually had ALL, non-Hodgkin's lymphoma, rarely Hodgkin's disease, Hodgkin's lymphoma, a lot of arthroplasties in these girls. And what plays a very important role is the amount of dexamethasone. It's not any steroid that can cause this, but dexamethasone is a hell for these children, for these young girls. So here you can see a child with bone infarcts after steroids at 13 years old, improving later. Sometimes we have bone necrosis at the time of diagnosis, and we have published, but I don't have pictures of that. We didn't have pictures at that time. 2 children with bone marrow necrosis, and at the time of diagnosis of acute lymphoblastic leukemia, and when you aspirate, you have a hard time to aspirate, first of all. And then you look at your material, and it is like a jello. I mean, it's gelatinous, you know. And these children do very well. They do very well. And this is a patient of mine, 4 years after the completion of her chemotherapy. This was her first avascular necrosis, and then she had in the other femur as well, and she had arthroplasties in both. Not only steroids can cause various problems in the bones and the bone marrow. We have methotrexate toxicity, rickets from ifosfamide, the ATRA, either cis or not, that we give also in neuroblastoma today. They can cause cortical hyperostosis and secondary tumors from previous chemotherapy and or radiotherapy. We, as pediatric oncologists, we always find this paper very interesting. It's very old. When Professor Tanabe first presented his patients, and his patients were these, there were 39 children. They had MRI in both femurs, and he was able to find metastatic disease in 24 of 39 children, and most of them had in both femurs. He appreciated 2 types of involvement of the bone marrow. In the majority, there was diffuse involvement. Fewer had nodular disease. And what is important, and I'm going to show you in a graph, is that if the disease, the neuroblastoma patients, has bone marrow metastases, nodular, then 100% improve after chemotherapy, whereas with the diffuse, which is the majority, very few improve after chemotherapy. And not only they disappear, the ones with the nodular pattern, but they have very good survival curves compared to those with the diffuse disease, and the disease persists after chemotherapy, and they don't do well at all. Okay, you will tell me, okay, stage 4 neuroblastoma doesn't go well anyway, but that's another marker, let's say, if you have nodular metastases and disappears after chemotherapy. And this is a review of imaging definition for bone and bone marrow in neuroblastoma. It has been published lately, 2 years ago. But just here is the paper by Tanabe. But keep this in mind, that with MIBG, 6 of 15 bone marrows were able to demonstrate disease, and 4 of 15 bones, compared to 5 of 12 with MRIs, which is not very good, as you understand, for the bones. So, but we have also PET-CT, we have MIBG, and we have what we have to do and what we have been doing for years and years. Here we have a diffuse infiltration, nothing to do with the diffuse infiltration in the bone marrow in the MRI. And we have the clusters or the rosettes. So we have an easy way, rather easy, to demonstrate metastatic disease in the bone marrow. So, bone marrow assessment, okay. MRI is a very valuable tool. However, we need to always judge clinically our patient. We should not forget old-fashioned approach as this. For the Greek people, you understand that this patient is dreaming of her doctor being downstairs and doing to him a bone marrow aspiration. Or to look, myself with Sophia, the girl with the Burkitt's leukemia, the microscope. And I noticed there is a book, which of course I didn't open because I don't have it, Pediatric and Adult MRI Atlas of Bone Marrow. I'm sure you are aware of this. Thank you very much for your attention.